In this episode, we're exploring what patient experiences can teach us about the strengths, weaknesses, and blind spots within modern healthcare systems. To help us unpack this topic, I'm joined by Suzanne Cromme, psychologist, research, and doctoral candidate focused on women's healthcare, patient experience, and healthcare innovation. Suzanne, can you tell me a bit about your experience? How did you land here today?
How did I land here today? Well, my primary experience is in women's health research, and primarily I'm looking into women's health experiences in outpatient hysteroscopy, so their gynecological health experiences. I came across quite a few shortcomings through the research, and I realized that in order to really change something, you have to look at health tech innovation, because the system as it stands isn't cut up for it anymore. It has never been designed for it to be used the way it is being used today. So it doesn't meet all the patient needs. So it's primarily my passion about women's health research and making sure that their voices are being heard.
What are the biggest gaps that you're noticing in the research and/or in care delivery today?
Biggest gaps that I am noticing primarily are around, I would say, person-centered care, particularly for women, but generally as well. I think that women are underinformed about their own conditions, but then they are also dismissed in terms of symptom presentation, particularly around pain. And I would also say that I feel that consent processes for women attending outpatient gynecological clinics are not good enough. So I feel that they fall very short of about 3 stages that should be included beyond the signing of the form.
What does good healthcare look like? What does a proper consent form look like? Do we have examples from around the world or in your research?
So with consent, you have to define in the first case what it is, what it means, what it's there for. So oftentimes it was used as a way to cover any healthcare providers from potential litigation against them. But also it was about, okay, is the woman informed enough? Can they make adequate choices based on the information that has been provided? And once they say, yes, I've understood and I accept what's going to be happening, then they can sign or give verbal consent. I do think that in gynecological procedures, though, that isn't enough. So I feel that there needs to be a novel framework that needs to be developed as a sort of moving consent, so that there needs to be various stages of consent. So the first stage could be along the lines of, yes, I agree to turn up for the procedure and see whether I still want to perform it on the day. The second one would be, okay, I'm here now and I'm still okay to go ahead, because a few things can happen between giving consent and then turning up on the day. And now this is the critical part, is with outpatient gynecological procedures, they can be very painful. And oftentimes in the consent literature and patient information literature, the pain that women are expected to experience is minimized as period-like cramping, some mild discomfort, and that's it. But we know from the research evidence base that women would categorize the pain that they're experiencing as much more severe and traumatic. And so they then need to be able to, so as they're sort of having the procedure done, if the pain is adequate, then they can reconsent and say, okay, I'm okay to go on. Or they say, this is too much, I can't take this anymore, it's unbearable. And then secondly, and this is particularly with diagnostic and outpatient gynecological procedures, particularly for hysteroscopy, is that when the diagnostic procedural part is completed and they find a polyp or some fibroids, or they need to maybe take a biopsy, or they need to perform uterine ablation, that is a separate procedure. It doesn't fall under the consent of the original procedure. But oftentimes then there's that time pressure that clinicians feel, and they don't want to expel the woman back into the system to then have to wait further for an additional procedure. So they say, let's just do it now. But it is a procedure that requires consent. So if there's a change to the procedure or an add-on procedure, that needs to be consented to. And oftentimes women are being placed in the position where they have to advocate for themselves. They have to say, stop, it's too painful. Or they have to say, tell me again, what are you going to do now? Rather than this built-in structure where the consent leads you through the procedure, through these different stages. And the clinician then says, how are you going? Is this okay? Are you comfortable enough? Or I have found this and that. I would suggest we do this, but it's up to you. Do you think you can keep going? Right? Yeah.
So how can we use technology to facilitate this process and help women be better advocates for themselves?
First of all, I don't want them to be advocating for themselves, to be honest. I think the healthcare system, this is where we go back to the patient-centered care. I don't think it's going to happen under the system the way it is now. You need to look at it from a systems perspective and from a patient perspective. What does patient-centered care even mean? So from a system perspective, it's about, okay, well, we want to make sure the right treatment goes to the right patient, right? That's patient-centered. But the way that the system is built, it is built for efficiency, focused on disease diagnostics, and then move on. It's all about the flow of procedures. And so if you're then saying to a clinician, I want you to be more patient-centered, spend more time with a patient, find out more about their sort of background and so on to provide a holistic experience for them, well, then that's not going to be happening within a 10-minute appointment. And so that's the system problem. It's fragmented. It is sort of time pressured. It is focused on the wrong outcomes, essentially. And from a patient perspective, I think patient-centered care often gets there's a misconception around what it is. So patient-centered care, often people think, the doctors just need to listen more and better and then be empathic. When actually that's not what it is. And this is where the behavioral science component comes in. You need to understand what the goals are of a patient, where they're coming from, what quality of life means this is enough. There is not a perfect answer for every patient. So you need to understand the underpinning components that get people to engage in their care, and to also engage long-term, to keep being invested. And so I would differentiate and sort of see two parts. It's the system level and the patient level. And behavioral science is all over both of them.
I would love to double click on behavioral science and unpack what are those trigger points, or I don't know how to define them.
So there isn't one model that you can apply to any health setting. And this, obviously, there's different behavioral models, but particularly in healthcare, you've got, the COMBI model, you might have come across it. You've got behavior change technique taxonomies and ontologies. So it's all very academic. But essentially what they do is it was developed to sort of categorize different types of behavior. And they did that by analyzing hundreds of different intervention types and then categorizing and cataloging different types of behavior in order to understand what gets a person to do what they do and what gets a person to not engage with a behavior, even though they know it's good for them. And so this is why, at this convention, I get quite frustrated, to be honest, because I think there's a lot of sort of focus on the next shiny thing, the technology. Oh, look at this. We're streamlining this and data. But actually, nobody is really looking into how do you engage the patient so that they get the outcome that they want? And so the behavioral science components around, let's take this beyond information. It's not enough to just do tracking of symptoms and, body fluids and all of that stuff. You actually need to understand, okay, now we have this person. So we can use a case scenario where essentially if two women get the same diagnosis, one woman, based on the data that they had submitted, one woman would then straight away make an appointment and be quite proactive in her care, and another woman might not. And we need to understand the behavioral levers that sit underneath to create opportunities for them to engage, to have that motivation, to reduce friction and so on. And so I think what we see here is very much the starting point. This is not the be all and end all.
I'm curious, is behavioral science contextual or cultural? So I think about, I'm Eastern European, very different cultural norms when it comes to medicine and certain procedures being very taboo versus now I live in the United States, very different culture, very forward about healthcare innovation, always trying the latest thing. So from the behavioral science perspective, do these translate from culture to culture to culture?
I think cultural components inform these different levers. So say, for example, what is important to you may be informed by the cultural background that you have. What's important to me would be informed by my cultural background. But essentially, it is where the motivation is, where the incentive is, where the different sort of motivational and opportunities are as well. And so, yes, there's absolutely an influence, but the components don't change. They translate. The culture influences the components, if that makes sense.
Were there any technologies that inspired you or encouraged you that you've seen on the show floor or that you're aware from the research where you want to see more of that.
Yes. So just to give you a bit of a background, what came out of my research into outpatient hysteroscopy is that women have to bear a lot of pain during these gynecological procedures, and that it's baked into the expectation of being a woman. Okay, well, you experience pain when you're menstruating, so what's a little bit of pain during a gynecological procedure? Same with giving birth and so on. What came out of my research is that, there were massive issues around consent, so the information was faulty or misleading, say, and that women were consenting procedures that they'd been told were like a smear test when actually it's a completely different procedure. But then we go into more hotter topics that can be quite polarizing. So what came out of the research as well was that there was medical misogyny, gynecological pain gaslighting. There's the gendered care component that, the care provided for men or access to pain, analgesic pain medication is much more readily available for men versus for women. And so, but generally, the main part that came out of it was around pain. It was the theme of pain roulette. On the one hand, women didn't know whether they were going to experience pain or not because there weren't any pain risk factors that have been researched that makes one woman more likely to experience pain than another. But also the lack of standardization in the UK amongst trust in terms of the analgesic protocols that are being offered to women is baffling, to be honest. So, some women will be told you get a self-administer and buy yourself a gram of paracetamol, so a couple of headache tablets before the procedure. And then others are being told, no, we can only do this under general anesthetic, even if you want to do it in the outpatient setting. And oftentimes these are adjoining boards within the same trust. And so there's a lot of over-standardization and not enough standardization in terms of offering a whole array of pain medication to women. And so what I'm excited about at this convention is these products that seem to disrupt the need for these invasive procedures in the first place. So you've got companies like Day who've developed a tampon that analyzes the microbiome for various biomarkers and that you can then send in. You essentially do your own testing in your own time at a time that's suitable to you in the privacy of your own home. So culturally speaking, we're talking about it before, it just accesses those sometimes marginalized communities as well, where the culture gets in the way of accessing healthcare. But otherwise as well, for very busy working women or mums, just being able to do that yourself is brilliant. And so that fills me with a lot of hope.
You mentioned the differences in gender on the patient side, but are there differences when the clinician is a different gender and how they handle the case?
Yes. So, I haven't done any research into that, but actually I attended the World Congress for Gynecology and Obstetrics last year, and they had that as a debate. So they had two people presenting their case as to who makes a better clinician, the female or the male. And they were going through all sorts of research that had been done, and they came to the conclusion that the gender doesn't matter.
Oh, okay.
Having said that, I do think we need to tread quite carefully there, because I do feel that in gynecological procedures, because it is such an exposing environment, I do believe that it could, whether the gender itself makes a difference or the perception of the gender by the patient is the issue here. That remains to be seen. But if you have a preference for one gender over the other, I do feel that women should be given the choice.
Everybody's talking about AI at this conference. Yeah. Are there specific applications and use cases where you can apply AI to solve for the problems that you're noticing in the research?
I think one of the worries that I have more generally speaking is that it could widen the gender gap, the gender health gap.
How so?
In the sense that it is built on being fed evidence and science and insight, or also cultural interpretations of certain sort of insight as well. And if you think about how women have been historically underrepresented in research, the women's conditions have been under-researched as well. And like Dame Leslie Regan said yesterday at a talk, women aren't just little men. We are our own entities that deserve research. And so what I worry about is that, first of all, the research we don't have enough research into women's health generally, whether it's women's specific conditions or just general conditions, but having researched women. But also, I think generally, if you look at who's programming AI, it is predominantly men. Who is funding AI companies? It is predominantly men. So I just feel that there could be a systemic bias that is going to repeat and widen the gender health gap. That's my worry. I hope it won't be the case. I don't know enough about AI in detail to be sure of this, but that's my worry.
Because you're so deep in the research, what advice do you have for founders that are both male, female, multi-gendered, that are building for femtech? What advice do you have to them when it comes to the research? How should they know what is valid and where there may be bias and how to navigate some of those dangers?
So there's a big move towards PPI in research. This means patient and public involvement. A lot of this research now does not get funded if you do not have a patient body or a body of the public, essentially, feeding into and designing interventions with you. And I don't see enough of that on the floor here where patients are the central voice. I think people get carried away, like I said before, by the shiny things. And it is exciting. I get carried away as well. But I do often come back to this idea of, well, where's the patient in all of this? And so my advice to any founder would be get some patients whose sort of diseases or illnesses or who you're trying to support and really listen to them. Do some qualitative research. Don't just look for quantitative data. It's the juice is in the qualitative data.
Would you advise them to work with the PhDs and the researchers?
Yeah, absolutely. And I'm very sort of spread out in terms of trying to not work in silos. And this is why I'm here as well, essentially, is because I haven't seen a single other researcher, by the way. I know there's a couple of research hubs, but they are also here for the innovation rather than the bottom up sort of, patient experience. But I would love it if we had researchers, clinicians, tech developers, programmers, whatever you want to call them, marketers and the venture capitalists, if you bring them together and sort of working together is much better than developing things in silos and then touching base and seeing whether that's going to work. I mean, if you want to solve a problem for someone, shouldn't you ask them how they want it solved? That's yeah. So definitely, I think if you want a really good, solid foundation for your product, you need to ask the people whom it's meant to help. Yeah, I love with researchers.
Is there anything I did not ask that you would love to share with our audience?
That's a really good question. I could sit here for hours, but yes. I don't think so. I think maybe around the future of sort of patient-centeredness around within healthcare. Like I said before, I don't think the healthcare system was built with the intention of supporting the demand that we experience nowadays. I think the demand has changed so much and we risk just developing more and more add-ons to the system when actually the system needs to be completely destructed and rebuilt. And I know that's a really tall order, but you did hear the CEO of the Mayo Clinic saying the same thing. I was like, yes, but who would be responsible for that? Is this also something that has to work between countries or within a global setting as well? But I think that's where AI could be incredibly potent going forward. Not so much on solving lots of little things, but think big and then create.
Thank you so much for your time. That was
wonderful. Thanks for having me. It was a pleasure.
Appreciate it. Thank you for joining us for this episode of the Akros Advantage. Healthcare is one of the most complex industries in the world, and every conversation in this series explores a different piece of that puzzle, from innovation and patient experience to commercialization, investment, and systems transformation. A special thank you to our guests for sharing their expertise, experience, and insights with us. If you enjoyed this conversation, be sure to subscribe, follow along, and explore additional resources from Akros Advisory, including our newsletter, where we help healthcare innovators navigate the path from idea to impact. Until next time, keep asking better questions, challenging assumptions, and building solutions that create meaningful value for the people they serve. I'm Demi Radeva, and this has been the Akros Advantage.